Hey, this is Dr. Avinash. Welcome to chapter number 33. Here we are going to talk about antidepressants. Of all the mood disorders or affective disorders as they are called, major depression and mania are the two extremes. We have handled mania in the last video. This video is going to be all about major depression. A patient with major depression will have sad mood, loss of interest and pleasure, low energy, worthlessness, guilt, psychomotor retardation, or sometimes even agitation. And they have changes in appetite, sleep, they have melancholia, suicidal thoughts are there. And these are not good thoughts to have. Telling somebody who is depressed to not be depressed is stupid. We need to do something medically about it. And that's how we came up with the idea of having antidepressants. Simple. A huge category of drugs, like there are so many subtypes of this. Reversible inhibitors of MAO-A, tricyclic antidepressants, SSRIs, SNRIs, and then the newer atypical ones have come in the market. As far as we are concerned, we need to know what is MAO inhibition. MAO is a mitochondrial enzyme that is involved in breakdown, oxidative deamination of amines like adrenaline, noradrenaline, dopamine, serotonin. It is thought that depression happens when dopamine, noradrenaline, adrenaline, serotonin, these neurotransmitters are less. Out of these four, if I have to pick two, it's adrenaline, noradrenaline and serotonin. So if you can somehow increase the level of noradrenaline and serotonin in the brain, then you automatically change depression into being normal. Now for that, what we do? We block the enzyme MAO so that these monoamines are not broken down. Simple, cool. There are two monoamine oxidases, MAO-A and MAO-B. MAO-A preferentially deaminates serotonin and noradrenaline, the neurotransmitters that we are interested in this particular chapter. MAO-B deaminates phenylethylamine. That's different. Okay, we are not interested in that in this chapter. Some other chapter we will probably talk about MAO-B. Now, another thing that you have to know so that things become easier later on is cheese reaction. When you block MAO, you not only block the ability of our body to break these monoamines, but substances such as tyramine and dopa are also not broken. Tyramine and dopa is present in pretty large quantities in cheese, beer, wines, pickled meat, fish, yeast extract. Now, if you recall, tyramine and dopa are indirectly acting sympathomimetic amines, which means they go inside the body. They themselves are not sympathomimetic, but they cause release of noradrenaline. So imagine this happening. Somebody has been given a medicine which is MAO inhibitor, a permanent MAO inhibitor, like it has blocked it, and that person eats these things. Then in his intestine, tyramine and dopa, which is generated, that will escape degradation in the intestinal wall, in the liver. It will reach the systemic circulation. In the systemic circulation, they will cause release of large amount of noradrenaline, and as a result, the patient will get hypertensive crisis and cerebrovascular accidents. This is known as cheese reaction. Please note, cheese reaction is not just because of cheese, it is because of many other things which contains tyramine and dopa. Not only that, any other medicine that is indirectly acting sympathomimetic, even a little bit, that also will give you similar reaction called as cheese reaction. So this can happen with cough cold remedies which contains ephedrine or some similar drugs like that, as well as TCAs, tricyclic antidepressants, SSRIs and SNRIs, and levodopa. So when patient is taking these things, please tell the patient, kindly don't overeat these substances. So there will be some dietary restriction on this patient. Okay. Moving on to the first potential answer, this is rare to come but can come, moclobemide. This is favorite in vivas though. This is a RIMA, reversible inhibitors of MAO-A, and it is selective. Good news, short duration of action, and if you stop this drug within a day or two, full MAO activity is restored. Good news, this is a competitive enzyme inhibitor, right? Which means normally when you give moclobemide, MAO-A is inhibited because there is no competition. Nobody else in our body is trying to inhibit MAO-A, right? But when you give tyramine, the tyramine can easily displace moclobemide. Getting it? Tyramine can compete with moclobemide for MAO-A, and then tyramine will be acted upon by the enzyme. I hope you are getting it. See, both moclobemide and tyramine can attach to the enzyme. Simple. But MAO-A can break tyramine, can destroy it. Simple. Moclobemide is not destroyed. Moclobemide binds and inhibits. So the good news is, if somebody eats all these substances that we have been talking about, he doesn't need to worry, because when these substances enter into his intestinal cells, into his liver, they will displace moclobemide. The MAO-A will act on these tyramine and other such substances and break them down. And then again MAO will be inhibited because of moclobemide. So that is the reason why there is no significant pressure response to amines that are ingested, and no dietary restrictions are thus required. It is a good antidepressant. In severe cases it might not work, but otherwise it does work. It does not have any anticholinergic property, no sedative, no cognitive changes, no psychomotor cardiovascular adverse effects. See how nice this drug is. So this is safer. Even in overdose, this is safer, and that's the reason why we love it as an alternative option in elderly patients. Adverse effects are nausea, headaches, dizziness, insomnia, very rarely excitement, and some liver damage can happen. It does not really interact with drugs or alcohol, but be cautious when you are co-prescribing pethidine, SSRIs, TCAs. They are good for social phobias. Then came imipramine. It was the brother analog of chlorpromazine. Imipramine selectively benefited depressed patients, not agitated patients, and we realized that imipramine is blocking the neuronal reuptake of noradrenaline and serotonin. This is what I am trying to say here. When action potential comes at the end of a noradrenaline secreting neuron or a serotonin secreting neuron, then what is released in the synapse? Noradrenaline or serotonin, right? The action of this synaptic noradrenaline or serotonin can be terminated by removing the noradrenaline or serotonin. How do you remove this? We have special transporters called as reuptake transporters. What do? Once noradrenaline is released, once serotonin is released and their work is done, they are immediately picked back up by the presynaptic neuron by using reuptake channels. Simple, easy. What would happen if you block those reuptake channels? The serotonin, the noradrenaline will remain in the synapse for a much longer period of time. Am I correct? And if it remains for a much longer period of time in the synapse, then logically it will work more. And if it works more, depression goes away. Very soon we had large number of tricyclic antidepressants. In addition to blocking the uptake, the reuptake, they also have cholinergic, adrenergic and histaminergic receptor actions. And these led to side effects. These are called as first generation antidepressants. Simple. So of course we did not want this side effects. So we created second generation antidepressants that are more selective. They act specifically on serotonin reuptake or only serotonin and noradrenaline reuptake. They have no direct cholinergic, adrenergic, histaminergic receptor action. Okay? Or maybe they have some atypical features, but they do not have this, which was good because now the side effect actions will be lesser. Let's talk about pharmacological action. Let me again remind you, reuptake is blocked. For noradrenaline reuptake, we have a pump called as norepinephrine transporter. For serotonin reuptake, we have SERT, serotonin transporter. They are located both on neuronal and platelet membrane, and these medicines are going to block both neuronal and platelet membrane channels. They also can interact with muscarinic, alpha adrenergic, histamine H1, serotonin 1, serotonin 2, and sometimes dopamine D2 receptors, and this is what gives side effects to the first generation, the tricyclic antidepressant drugs. Okay, of course, individual drug potency will vary at all these different sites. If you give antidepressant, tricyclic antidepressants to a normal human being, there is no mood elevation. It's not like depression becomes elevated mood. No. It's not like the patient will get euphoric. The patient actually has unpleasant effects, like a peculiar clumsy feeling. The patient becomes tired, lightheaded, sleepy. They have difficulty in concentrating and thinking, and the gait becomes unsteady. See, nothing of this is normal. People will get anxiety because of it. Simple. In depressed patients, the effects are completely different. Like nothing happens in the first 1 or 2 weeks except little sedation. But after 2 to 3 weeks of continuous treatment, this mood slowly and gradually becomes better. Patient becomes more communicative. They start taking interest in self and surrounding. So basically, you can't think of TCAs as euphoriants. They are antidepressants. Now, most of the depressed patients, they have more of REM sleep. This phase is suppressed. The nighttime awakenings are reduced. So these patients can actually sleep better. Almost like what happens in hypnotics. Okay. The sedative property will vary. Different medicines will have different sedative properties. But imagine a patient who has anxiety and agitation. You will prescribe a medicine which is more sedative. Simple. And if a patient is withdrawn and retarded, give a less sedative or less, kind of give a stimulant one. And that would mean that the patient will be more active, right? The drawback is TCA's lower seizure threshold, which means they can produce convulsions. MCQs, clomipramine and bupropion have the highest seizure precipitating potential. What is the mechanism of action? Well, we already know the mechanism of action. Let us put it in proper words. TCAs and related drugs, they inhibit NET and SERT. NET and SERT. These are the transporters which mediate reuptake of amines, noradrenaline and serotonin, into their respective neurons. By blocking them, we are increasing the potency of noradrenaline and serotonin by increasing their availability in the synaptic cleft. I hope things are clear. By not taking them back, noradrenaline and serotonin will remain for a longer period of time in the synapse, and which means it will work for longer. Okay. Now, the antidepressants differ in their selectivity and potency for different amines. Okay. Most of them have little action or no action on dopamine reuptake. Bupropion does have dopamine reuptake blocking ability, but others don't. Amphetamine and cocaine, they are not depressants, they are inhibitors of dopamine uptake, not noradrenaline and serotonin. Okay. So what we have understood from this is, if you inhibit noradrenaline and serotonin reuptake, there will be antidepressant action, and if you inhibit dopamine uptake, it will be stimulant action. Okay. This is where you should stop reading for your exams and directly jump to ANS action, because these two are theories that we have: the neurotropic hypothesis of depression and monominergic hypothesis of depression. So if you have time, then you might. I am not interested in wasting your time talking about things that will not come in exam. Most TCAs are potent anticholinergics. Oh, anticholinergic is like atropine. So patient will have dry mouth, blurring of vision, constipation, urinary hesitancy. These will be side effects. Right? Simple. Now, the TCAs potentiate exogenous and endogenous noradrenaline. How? By blocking its reuptake. But some also have alpha adrenergic blocking action. And some, like amitriptyline, doxepin, trimipramine, they have H1 antihistaminic actions. There are some CVS actions also. These CVS actions are prominent. They happen at therapeutic doses such as tachycardia. This is because of anticholinergic and noradrenergic potentiating action. Postural hypotension because of alpha-1 blockade plus inhibiting cardiovascular reflexes. And we have noticed ECG changes and cardiac arrhythmias such as T-waves inversion, most important one, and arrhythmias in overdose because it will interfere with intraventricular conduction. Okay, remember this much, more than sufficient. Easy? Cool. Now these drugs do have something called as tolerance and dependence. Tolerance, luckily, is for the anticholinergic, the hypotensive effects, and slowly and gradually these side effects will go away. The antidepressant action remains sustained. So as a result, even though tolerance develops, it is tolerance to the side effects and not to the main action. Addiction is rare because none of these drugs produce a pleasant effect. But there is some physical dependence, especially when high doses are given for a long period of time. When we stop these medications, people tend to get malaise, chills, muscle pain. Okay, these are considered as withdrawal phenomena, but to avoid this, gradually withdraw them. Simple. There's no abuse liability. As far as pharmacokinetics is concerned, I don't think you should be worried about it. Okay, you can skip this part, except if you want to like really do amazing with your MCQs. Then the therapeutic window phenomena has been obtained or observed, where optimal antidepressant effect is exerted only in a narrow band of plasma concentration, that's 50 to 200 nanograms per ml of imipramine, amitriptyline and nortriptyline. You go above this particular dose, the effect does not increase, side effects increase. You go below this particular range, the action will not be there. Okay, now even though we do know some of these medications have a therapeutic window, you have to understand that everybody's moods, everybody's depression level will be different, right? And everybody's bioavailability will be different, everybody's metabolism per se would be different. So as a result, there is a wide range of plasma concentration achieved by the same dose. So you individualize the dose, you titrate the dose with the response. Okay, plasma concentration is not a good guide, except for those 2-3 drugs that we spoke about. The main side effects, okay, and these side effects are common with TCAs because of which the other categories as the SSRIs, the SNRIs and the atypical are now the chosen drugs. The TCAs have anticholinergic side effects. You remember anticholinergic drugs? Atropine. Write their side effects: dry mouth, bad taste, constipation, epigastric distress, urinary retention. Especially elderly individuals, elderly males with enlarged prostate, they will have a serious problem. They might even have blurred vision and palpitation. Other side effects are sedation, mental confusion and weakness. especially amitriptyline, and there are some of the drugs which are more sedative. Increased appetite and weight gain has been noted with most of the TCAs, but not with the other drugs, the SSRIs, the SNRIs, and the bupropions. They are not really going to cause any of the weight gain. And some patient receiving antidepressant may abruptly switch over to a completely dysphoric, agitated state, or even to mania. It is suggested that these people were actually bipolar depression. We gave the medicine, the depression got rid of, and now the other end, the hypomania, mania, that is being unmasked. So the other pole is being unmasked by the antidepressant, is what concept we have. Apart from this, sweating, despite the antimuscarinic actions, sweating may be there, and fine tremors is there. We have already spoken about how seizure threshold is lower, so fits may be precipitated. Okay, compared to TCAs, bupropion, clomipramine, amoxapine, these three have more chances of causing seizure as compared to decipramine, SSRIs, and SNRIs. They are much safer in this regard. People have got postural hypotension, sexual distress is there, delay or interference in erection and ejaculation, and occasionally even with orgasms. So that does not happen. Cardiac arrhythmias can happen in patients with ischemic heart disease, and that can lead to death. And last side effect is rash and jaundice. Can these drugs cause poisoning? Yes, of course. And it's actually self-attempted for suicide or something, because these are like depressed people, right? We are giving medications to. So when someone takes too many of these medications, there's excitement, delirium, and other anticholinergic symptoms, like what is seen in atropine poisoning, followed by a muscle spasm, convulsions, and coma. The respiration is depressed, the body temperature falls, and BP becomes low, tachycardia is prominent, and you already have understood about the arrhythmia. So whatever we spoke about in side effects, just exaggerate it instantaneously. Okay, treatment is going to be supportive, which means we are not going to do much. We are going to give gastric lavage, see to it that the patient is breathing properly, give proper fluid infusions, maintain the BP, maintain the body temperature. If there is acidosis, you correct it by giving bicarbonate. If there is convulsions and delirium, give diazepam. Important to treat cardiac arrhythmias, so for that we can use propranolol or lidocaine. That is that. There's no more medications to be given. Okay, just wait for the body to metabolize the TCAs and throw it away. Simple. Which brings me to the next question: selective serotonin reuptake inhibitors, or SSRIs. The reason why SSRIs came into being is because the TCAs had limitations. Frequent anticholinergic, cardiovascular, and neurological side effects are there, right? Not only did they have anticholinergic and cardiovascular neurological side effects, if you recall, they had a narrow safety margin, low safety margin. So if TCAs were taken in overdose, there was still a chance of fatality. And significant number of patients did not respond properly, incompletely. Some did not respond at all. So the second generation antidepressants were developed. Okay, most of the important ones are included in SSRI and SNRI categories. The SSRI selectively inhibit only SERT, and the SNRI inhibits both SERT and NET. Okay. Some people might still not respond, but comparatively the efficacy of second generation antidepressants is much higher than the RIMAs and the TCAs. Simple. The good thing about this is, if SNRI does not work, try SSRIs. It might work. The newer drugs have improved tolerability at therapeutic dose, has a better safety margin. Okay. Plus, some drugs claim that they have a faster onset of antidepressant action, but many studies are still unequivocal about it. They are not sure about it. Now, because of the safety margin and better acceptability by patient, SSRIs are now the first choice drug or first line drug in depression, and that's the reason why we have also used it in disorders such as anxieties, phobias, panic disorders, OCDs, and other related disorders. Basically, SSRIs have no or very little sedation, don't interfere with cognitive and psychomotor functioning, nor do they produce anticholinergic side effects. There's no alpha blocking activity, as a result, there's no postural hypotension, so even elderly patients can take it. There's practically no seizure precipitating property, so that is a benefit. They do not inhibit cardiac conduction, so even arrhythmia is not a problem. The side effects are gastrointestinal. All of them produce nausea, but even tolerance to that develops over time. Other side effects include loose motion. All these are side effects are because of selective serotonin reuptake inhibition. Okay, so uptake blockade in the gut will activate 5-HT receptors on the intestinal neuronal plexus, and that will cause loose motions and vomiting. Weight gain is not a problem, okay, in these drugs, but they interfere with ejaculation or orgasm by some mechanism. But overall, the new constellation of side effects are nervousness, restlessness, insomnia, anorexia, dyskinesia, and headaches. But patient still accepts them nicely. Very rarely we have reports of epistaxis and ecchymosis, maybe because serotonin is also important for platelet functioning, and that's gone. So maybe because of that. And gastric blood loss because of NSAIDs may increase because clotting will not happen. So keep this in mind when you're writing the answer. Like, this is very simple. Okay, they block serotonin. That's it. Now what we have realized is SSRIs can inhibit drug metabolizing isoenzyme cytochrome P2D6 and cytochrome P3A4, because of which many drugs levels will increase. But more importantly, and this is compulsory to know, serotonin syndrome is a manifestation of like agitation, restlessness, rigidity, hyperthermia, delirium, sweating, twitchings, lastly convulsions. This happens when any serotonin increasing drug is taken by patients who have SSRIs. So first of all, the serotonin was working for a longer period of time because of SSRIs, and now we are given extra serotonin. That would be serotonin syndrome. Okay. Some people actually get resistant or tolerant to the antidepressant action, and we have noticed that discontinuation causes paresthesias, body ache, bowel upset, agitation, sleep disturbance. Okay, but as compared to TCA, the hypomania episode will not happen. Okay, now because there is no psychomotor problem, there is no cognitive impairment, we use this drug SSRI over TCA for prophylaxis of recurrent depression. The drug that I want you to do from here is fluoxetine. It's a bicyclic compound, first SSRI to be introduced, and the longest acting, its plasma T-half is 2 days. And not only that, it gets converted into demethylated metabolite that acts for 7 to 10 days. So fluoxetine was approved for children under 7 years and older for depression and OCD. And but see, children, you don't want to put them on medications, right? So you try something called a psychotherapy, and if psychotherapy fails, then this medication. Agitation and dermatological reactions are much more frequent than other SSRIs, but because it has a slower onset, if a patient needs rapid control, this is not the primary drug. Okay. The second drug I want you to do from here is sertraline. This has gained popularity. See, when somebody asks you sertraline, don't just write this much, write this entire thing, this entire thing, because these all are points common to all SSRIs. I hope you're getting it. So you should be adding these points to your answer, plus write these extra things. SSRIs have gained popularity because fewer patients stopped taking sertraline because of side effects. And this is very good in juvenile depression. It's also good for anxiety and post-traumatic stress disorder. The enzyme inhibition thing is less likely to occur with sertraline, and that's the reason why we like this drug. Just know this. Okay. If you do this much also, it's more than sufficient. By definition, SSRIs are for depression. But then they are also the first choice drug for OCDs, panic disorders, social phobia, eating disorders, PMDD and PTSD. Okay, all of this. Simple. PMDD is premenstrual dysphoric disorder. This is almost like premenstrual syndrome, but this is a much more severe one, real troublemaker for many women before their menses start. So this is where we can use it. Easy. We've also used it for anxiety disorder or body dysmorphic disorder, where the females, mostly females, they can't understand that they are looking good or decent. They always find defects in their body. Or there's something called as compulsive buying disorders, kleptomania, where patients steal, and premature ejaculation. So they are also being tried for this. Okay. For patients who have just had a heart attack and chronic somatic illnesses, when we give them SSRIs, they generally tell a positive outlook has come, increased work capacity, elevated mood. So even when we want to improve outlook on life and to feel good in apparently non-depressed patients, you can try SSRIs. Whether to give or not is your decision, because it does not make ethically correct case for itself. Just because you want somebody to feel good, giving a drug does not make sense, right? So yeah, there are questions on that, but I hope you have understood this. The next one is SNRI, serotonin noradrenaline reuptake inhibitor. That's you need to know something called as venlafaxine. Novel antidepressant. It's called as an SNRI because it blocks the uptake of both serotonin and noradrenaline, but it does not interfere with cholinergic, adrenergic or histaminergic receptors, nor does it have sedative properties. Okay, it is as effective as TCA, so in resistant cases this might work. It has a faster onset of action. Simple. Plus mood changes, hot flush in menopausal syndrome, social anxiety, eating disorder, they all are benefited by venlafaxine. It does not produce the side effects of TCAs. Instead of depressing the blood pressure, it raises the blood pressure, and it's very safe in overdose. The only side effects are nausea, sweating, anxiety, dizziness, and impotence, and withdrawal reactions on discontinuation. I would recommend doing bupropion. Important. If you have time, have a look at mianserine. Bupropion is an inhibitor of dopamine and noradrenaline uptake. And instead of being a sedative, it is an excitant. Bupropion goes into the body of the patient, gets metabolized into an amphetamine-like compound, which causes presynaptic release of dopamine and noradrenaline. So bupropion is nowadays used as a sustained release formulation to stop smoking, because smoking happens when you don't get that excitement. Most people smoke for that kick, which can be achieved by giving bupropion. Okay, so nice results have been obtained in smoking abstinence. Quitting rate has been higher, as great as nicotine replacement, those patches, way higher than placebo. So this works. It activates the reward center, the dopaminergic reward center, bupropion, and that means the patient, when he takes this medication, he feels happier, better, and does not surge out for cigarettes. Better results if you combine this with nicotine patch. Okay, and the withdrawal symptoms are very less. So people will leave cigarette smoking much easily when they are on bupropion. It is known to cause insomnia, agitation, dry mouth, and nausea, but there is no sexual side effect, and as a result, this is preferred drugs, especially in the younger generation. Seizures can happen in overdose or in people who already have had seizure disorders. They are predisposed to seizures, so be careful in them. The dose of 150 mg BD should never be exceeded, and it is contraindicated in eating disorders and in bipolar disorders. MCQ. Apart from this, bupropion, see, everything that I have spoken till now does not talk depression at all. I spoke about cigarette smoking. You can use it to treat depression, but it should be the regular one. If it's atypical, then bupropion might not work, or you can add SSRI plus bupropion, so that combination might work. Does not work for anxiety disorder at all. So this much is what you need to remember. So where do you use all these medications? Well, there are 10 important uses. The first one, of course, is this chapter is depression, antidepressants, right? So this is endogenous depression or major depression. Okay, the aim of the therapy is to relieve symptoms of depression and restore normal social behavior. Okay, please understand, antidepressants are not to be given for everyone. You can't be like, oh, somebody lost a job, antidepressant, somebody lost a family member, here have an antidepressant. No, these are part and parcels of life. You need to be able to overcome them by your own. Okay, that's something that you need to understand. But SSRIs, SNRIs, atypical antidepressants may be tried even in these illnesses. Major depression definitely requires antidepressant medication. These drugs have proven value, but the response takes some time. Full benefits will be still longer. We have already discussed this. Which drug will you choose? Depend on the patient's condition and the drug's property. Okay, plus the past history of drug response if it is available. But as of now, SSRI is the first choice drug because of their better tolerability, better safety margins, and higher efficacy. SNRIs are also good. Atypical is also good. You can try any of this. Okay, the only antidepressant that works in juvenile depression is fluoxetine and sertraline. Okay, TCAs are not really used. They're more like an exam question. TCAs are much more like second, third number drugs. Only when the second generation, the SSRIs, the SNRIs, they don't work, or patients are not tolerating the second generation drugs, then you can try this. Okay, if the patient still does not respond, try a medicine that works on other amines. Getting it? So if you are giving SSRI and the patient is not responding, try SNRI, because maybe in this patient it is not serotonin, it is noradrenaline, God knows, right? So you can try that way. Okay, so try giving single drug only. When single antidepressant fails, like you tried every combination possible, like every drug possible, then you may have to combine. So you can combine an SSRI with an atypical antidepressant like bupropion or maybe even lithium or valproate. So that's another option that can be done. Now you can skip all these parts, not really necessary. The next thing that we do is use these medications for OCDs, obsessive compulsive disorders. Fluoxamine, drug of choice due to better patient acceptability. TCAs are also effective. 50% patient will definitely get improvement easily, but it takes time. Okay, almost 2 to 3 months, and higher doses are needed for treating depression than that needed for treating depression. SSRIs and TCAs also are used for treating bulimia, that's compulsive eating, helps patients with body dysmorphic disorder who can't perceive their body the way it is. Okay, they always have complaints about their body, or compulsive buying and kleptomania. Will the habits go away completely? Nah, not maybe not. Okay, but at least control is achieved. Similarly, anxiety. Antidepressants, SSRIs and SNRIs exert a delayed but beneficial effect in many patients of social anxiety and generalized anxiety disorders. So you have to give benzodiazepines which act rapidly, and then you can give SSRIs, SNRIs, and then you can try and stopping benzodiazepines and only continues this SSRI and the SNRIs. They also help in phobias. They help in panic attacks, in post-traumatic stress disorders, mood swings, hot flushes. Can also be controlled. See, the ideal way of controlling mood swings and hot flushes, especially in menopausal women, is hormone replacement therapy, HRT. But there are some women in whom the HRT is contraindicated. Then what? Then you will treat it with these SSRIs and SNRIs. You can also give it for neuropathic pain. Amitriptyline, good for diabetic and other type of chronic pain. It also decreases the intensity of post-herpes neuralgia, post-herpetic neuralgia. SSRIs don't really work that way. The other drug that we have is an SNRI called as duloxetine. Very good. This is now the first line drug for diabetic neuropathy, fibromyalgia, and many other such conditions. Other drugs we have seen in other chapter, pregabalin, gabapentin can be used. So some doctors use the combination of duloxetine and pregabalin. It works. If monotherapy is not working, this is a good option. Now, some children have ADHD, attention deficit hyperkinetic or hyperactivity disorder. But the child really has trouble sitting in one place, just does not sit in one place, keeps on moving from one place to another. Okay, and TCAs like imipramine, nortriptyline, and amoxapine, which are less depressant, they will not put the child to sleep. They are good. The reason why we love them is because they have less fluctuating actions and fewer behavioral side effects. Okay, we can also use a noradrenaline reuptake inhibitor, atomoxetine. It's unrelated to either amphetamine or TCA. It's a new drug altogether, which is used specifically in cases of ADHD. So yeah, this is one use. Premature ejaculation in males. This is occurrence of ejaculation before or shortly after penetration, or with very minimal sexual stimulation. This is a very common sexual complaint actually, and many people actually perceive it as sexual weakness, and that causes lot of distress and dissatisfaction, not just for the patient but also in his partner. Also, the problem is you need to ask how much time is he able to maintain an erection, or what is the length of their penetrative intercourse. And you will realize that thanks to pornographic films, people have a horribly distorted expectation about their length of intercourse. Okay, you need to be able to explain that also to your patient, that maybe their expectation is wrong. Okay, that's not how things happen in pornographic films. These actors and actresses get chance to do a retake. In real life, that does not happen, and hence you may be expecting something wrong. But in case there is really a premature ejaculation case, then SSRIs and TCAs like clomipramine, they all delay ejaculation, they inhibit ejaculation, so they can be tried. Really speaking, for delayed ejaculation, premature ejaculation, the primary treatment is counseling and behavioral therapy. But sometimes you might need some medication, so dapagliflozin and SSRI can be used for this particular purpose. Acts pretty rapidly. 60 mg taken 1 hour before intercourse has helped many. Okay, we also have clomipramine 3 times a day. This is much slower acting drugs, and we need to take it for a longer period of time, like regularly, for maximal benefits. That's how things are. Okay, even 25 mg taken 6 hours before sex might really work, clomiframine. Okay, and then we have smoking cessation. We already have spoken about bupropion, already spoken much about bupropion. Just go through this, and if there is a query about it, let me know. Children above 5 years of age who are still bedwetting, you can try imipramine 25 mg at bedtime. The problem is when we stop the drug, bedwetting may start again. So there are other modalities of treating enuresis. We'll discuss that in pediatrics. And elderly subjects with bedwetting also have benefited by imipramine. Which brings us to migraine. Amitriptyline has some prophylactic value in mixed headaches, migraine headaches, and TCAs have antipruritic action. And topical doxepin has been used to relieve itching of atopic dermatitis and lichen simplex. So this is the only odd one out. Everything else is pretty much the action that we have studied. Go through this topic. Let me know if you have any doubts, and I will be very happy to help you. Till the next time we meet, this is Dr. Avinash signing off for now. Take care, keep studying and keep rocking. Bye bye.